Hello, I'm Dr. Dominic Bray. I'm a consultant clinical health psychologist with a particular interest in training and working with doctors and nurses and other allied health professionals. Today I'm talking a little bit about what goes on in primary care, in particular what goes on in consultations between GPs and their patients and families. And I'm going to suggest potentially that if the conversation's not working so well, maybe it's time to change the conversation. So I'm going to start off by talking about how sometimes things go wrong, what a viable alternative might look like, and then a little bit about the evidence base for that particular way of doing alternative conversations. So starting with the first, as we know, more and more people are living with long-term conditions. Of course, the irony here is that medicine, etc., is keeping people alive longer with unfixable kinds of things. So we're looking at 70% plus of NHS activity is about long-term conditions. And effectively, we have more and more and more people reliant on health services and a dwindling population, particularly amongst GPs, of health professionals there to serve them. Furthermore, we have inherited a model of working with people that, broadly speaking, in transaction analysis terms, could be defined as looking like this. Given that conversations tend to be broadly about people being in roles, parent, adult, child, very often we find ourselves, and GPs in particular, find themselves in the father, the parent position, the paternalistic position, as people would used to call it. And of course, by definition, that tends to put the patient more in the child role with all the obvious complications. Now, that's great if you have a nice easy fix like a broken arm or a quick referral to a hospital, but given that, again, we're talking about long-term unfixable conditions, that's not necessarily the greatest approach. We know that because there's a lot of non-compliance out there. You may know that up to 50% of the medication is not taken as prescribed, so something clearly isn't working so well. Furthermore, being in this role of being expected to do something clever puts a lot of pressure on GPs, I've noticed over the time, and it becoming increasingly unsustainable. So GPs find themselves in the position of keeping going, doing the same old thing, wishing it was better, but not having the time to do anything differently. And that would be called, of course, learned helplessness in the literature, which, as you may know, is a good predictor of depression. And yes, I have met enough depressed GPs out there in recent years. So, is there a viable alternative? Is there a different way of having that conversation? I would suggest the answer, in short, is yes. And again, coming back to our transaction analysis model, instead of parent-child, what would it look like if it was truly collaborative, much more of an adult-to-adult conversation? What if it was characterised by concordance, i.e. an agreement between the parties involved rather than compliance or non-compliance? Incidentally, the term concordance was not coined by psychologists. It was coined by the Royal Pharmaceutical Society of Great Britain because they noticed this kind of figure of medication not being taken as prescribed. So maybe, well, wouldn't that be nice, but is that even possible? How would you even go about having that kind of conversation? Well, here's some questions I prepared earlier. Some starters for 10, and these questions are used all the time, and we know GPs in Southport and other physicians elsewhere who use these kind of questions a lot. The classic question that begins to bring focus straight away to an appointment. The question is not, what do you want me to do for you today? Because rightly a patient may turn around to you and say, well, if I knew that, I'd be a doctor, wouldn't I? So instead, it's something like, what would you like out of this? What are you hoping will be better as a result of this? Not unnaturally, a lot of patients would say, well, I won't have pain. Of course, the key is the next question. So if you didn't have pain, what would be better? What would you be doing differently? And usually the answer is some version of I'd feel more like a useful person, I'd be a better dad, I'd be a better sibling, or whatever that would mean for that person. More purpose in their life. And so you're up and running with a conversation about something that's achievable, that doesn't just depend on you coming up with a magical remedy. Similarly, if you have someone who's quite entrenched and they're saying that nothing's ever better and I just can't keep going, ask them, well, what would you want to be telling me in a month's time? And of course, given that when people are on antidepressants, often you have to see them a month later anyway, it's a golden opportunity. When you ask people that question, very few people ever say, I want things to be exactly the same. So these questions could broadly be called, tell me what you want, what you really, really want kind of questions. Or for those with a sporting disposition, if you don't know where the hole is, it's a long day on the golf course. By bringing that kind of focus, you are narrowing down the conversation to what really matters and potentially saving time. It's a great way of people feel truly listened to. And then these could broadly be called questions that pertain to the donut rather than the whole. Because all our trainings, particularly medical training, tends to be illness-based. It's about what's wrong. Do we spend enough time noticing what's right? Because that's also legitimate information. It's what Simon Stevens would call people's renewable energy. So a great question, how have you got through things before? It's not what have you got through, it's how have you got through things before. And this is because we're reticent in a British culture to blow our own trumpet. I call this the Auntie Vera question. So, how would Auntie Vera describe your qualities? And if the answer is, well, Auntie Vera would say I'm bloody minded, and if I set my mind to something, I do it, then you're already up and running, aren't you? That's a great quality for that person to have. As I said, there is an increasing evidence base for this. You might want to look up Robin Youngson's book, Time to Care, where he talks about by investing a little time in that listening exercise, even in brief conversations, you're going to save a lot of time later and have a much more satisfied customer, you might say, and yourself have a more sustainable career. You might also want to look up the Royal College of GP's Collaborative Care and Support Planning Initiative. As I said, I'm involved in that, and there's a lot of useful material, including suggesting that rather than all the owners being on the conversation with the GP, maybe everyone in primary care should be having the same conversation. So to sum up, I'm suggesting that maybe it would make sense to change your style of conversation. Maybe what you're doing does not feel sustainable. Maybe there is a viable alternative. And after all, what have you got to lose?